Step into Office Hours with California's Doctor, where health meets real talk. Hosted by the California Surgeon General, these conversations will tackle health issues that truly impact everyday life. From mental health struggles to game-changing medical innovations in public health, we will dive deep into the topics that matter most to Californians and their community. Informative, empowering, and thought-provoking. Whether a professional advocate or simply curious about improving well-being, these conversations are a trusted source for insight and guidance. Your health is the foundation for a healthier future. Let's build it together. On this episode of Office Hours with the California Surgeon General, Dr. Diana E. Ramos sits down with Dr. Melissa Wong to discuss AI in maternal health.
Hello, I'm Dr. Diana Ramos, California Surgeon General, and it gives me great pleasure to introduce our speaker, our interviewee today, Dr. Melissa Wong. Dr. Wong is the Director of Informatics and AI Strategist, as well as Assistant Professor of Maternal Fetal Medicine in the Department of Obstetrics and Gynecology at Cedars-Sinai Medical Center in Los Angeles. Her research and work focus on designing and deploying artificial intelligence and clinical informatic tools that improve maternal outcomes, reduce disparities, and strengthen real-world clinical decision-making. She serves as the Vice Chair of the Society for Maternal Fetal Medicine Clinical Informatics Committee and is an inaugural member of Cedars-Sinai's AI Physician Advisory Council, helping guide system-level strategy for safe and equitable AI integration. Wow. Congratulations, Dr. Wong. So impressive. You are creating what we keep on hearing out in the field, out in the community is happening. So I am so eager to get started, and we'll start off with our first question. You're uniquely positioned, clinician, researcher, informatics leader. What problem in maternal care first convinced you that AI had to be part of the solution? Everyone is either friend or foe of AI. But tell me, what was your approach?
No, thank you. And thank you so much, Dr. Ramos, for having me here. So I like that idea of it being either friend or foe, because I would suggest that either way it's showing up to the party. So for me, I think that the first problem that really, sort of convinced me that AI would be a part of the solution really was actually around labor prediction. And this came from my background sort of before I was a maternal fetal medicine doc. I actually was a general OBGYN, so was, the person sitting, at 2 a.m. in the middle of the nursing station, with the other physicians and nurses sort of staring at a fetal heart rate tracing, staring at a labor curve and thinking to myself, like, what direction do we take this? Where do we go next? And the reality is nobody can know. Every labor, every pregnant person's course, every fetus's sort of response to labor is completely different. There's simply too many variables, and certainly nothing that could ever be captured in yet one more electronic health record form. And so that was sort of really the moment to me that thought, I can't do all of that, and a simple algorithm, and including when we've tried to sort of apply them in the past, really can't do all of that. But maybe this new thing, which at the time was a number of years ago, but this quote unquote new thing back in 2018, AI, maybe it can. And so that was the work that we started with, was this idea of being able to take all of those truly innumerable variables and innumerable variables considered over time, and be able to integrate for an individualized prediction as to a patient's labor course.
So important. The inevitable question when you admit someone to labor and delivery, whether somebody in active labor or an induction, meaning that we have to get them into labor, is what time will my baby be born? And how long is this going to take? And it sounds like the work that you are doing is really headed in the direction of being able to not only give patients more or less a general time frame, but the team on labor and delivery to know, okay, it's going to be a 3 a.m., 4 a.m. rush hour that we're all going to be hands on deck to be able to care for our patients. Can you share a little bit more details what that model that you helped develop actually looks like and how it's changing care at the bedside?
Yeah, absolutely. And while I wish I could indeed predict the exact time, it is not the direction that we have taken in our model, although that would make me, more popular among office bedding pools. But instead, it was really a focus on not telling people what they should do or what sort of proscriptively, must be recommended, but rather to provide another source for clinicians and the patients, ideally, to be able to guide their care. So, what the model looks at is essentially gathers all of the information from the antepartum course, so the prenatal course that we're able to get from their initial presentation into labor and delivery. As you alluded to, somebody showing up for an induction with an entirely closed, 0 centimeter cervix is going to have a very different sort of from the moment prediction than somebody who's coming in full active labor on their third baby and already 8 centimeters dilated. So it takes that information sort of initially into account, which admittedly, a lot of our models in obstetrics have done for decades, honestly. So that sort of admission prediction has not been the novel piece of this. What is novel, on the other hand, though, is that the model generates that initial prediction and then continues to gather ongoing information. So, the nature of labor is that it's constantly changing. The cervical exam is getting done at somewhat sporadic times. The methods that we're using to facilitate contractions, to facilitate, patient's own contractions, that changes over time. The fetal heart rate, of course, literally changes at our frequency that we're able to assess, 6 times per second. We sort of gather that information in an ongoing fashion. So all of those pieces are being taken into account to be able to deliver really just one central response in the end, which is predicting a patient's ongoing probability of a vaginal delivery. And then for that to ultimately provide guidance to the clinician, to the patient, as to what to do with that information, rather than unfortunately being able to say, 8 a.m., look out for it, but rather, for this individualized patient, really centering it on them. What is the probability that we can get to what their intended goal is, most times, which is a vaginal delivery?
Yes, thank you for that. Now, you said you've been working with AI and with models and algorithms since 2018. What would you say is one lesson you've learned in moving an algorithm from paper to real labor and delivery experiences for physicians and patients and the whole delivery team?
I think that what I've come to recognize is that this really takes a village to get this work done. And it not just sort of a data scientist and a physician, which was sort of the earliest work, but realizing that, you know, even the nature of the very questions that we ask has to involve physicians, nurses, patients, first and foremost, quite frankly, um, to be able to understand how we make implementations that eventually matter. So for example, we recognized, pretty early on that, in creating this labor prediction model, that had we just sort of gone with all of the data, which is what our data scientists had, initially conceived of and what was sort of everybody's instinct, especially, um, back in the early days of AI, we pretty quickly recognized that that would indeed get us a really predictive model. It would also, though, not actually change care, right? So it would essentially be recoding in what had happened in the past for the future. And so it was that early partnership, with a data scientist and with a physician to say, actually, we need to code this off of a targeted behavior. So a targeted behavior in this case being lowering the C-section rate overall and being able to do so safely, though, and equitably, both from the standpoint of pregnant person outcomes and neonatal outcomes. But that was a central goal, and the way that we could craft that then was to actually model specifically the population who had that targeted behavior, i.e. our lowest cesarean rate clinicians. And so I'd say that that's sort of the piece of it that my takeaway is that it really does take a village, from the standpoint of the folks who know what the data is and how we can get it, and then all the way up to the folks who are eventually going to be using it. And so as we created this model that was integral to the work that we were going to do, were also sort of the qualitative pieces of interviewing physicians, nurses, patients to understand what would this look like for you? How would it ultimately represent something that you could trust and would integrate into your care?
Yes, village concept, it really resonates. I think in all of medicine and in life, you can't do things alone, and you're better when you pull in a whole team of people to have better outcomes. And along that line with the members of that team, can you maybe go a little bit more into the patient contribution? You know, we oftentimes talk about using AI algorithms for by clinicians, but what would a patient facing risk tool need to get right to close, not widen the gaps of health outcomes and health care?
I will actually, in many ways, I feel like I'm going to plead the fifth a bit on this because I don't think that we know. It is a piece that I would love to see as a discipline, as a specialty, as a state maybe, that we really actively integrate into this prioritization around AI. So there really has, while there's been sort of I don't want to call it a token, but a bit of a focus on, sort of asking, like, are you okay with AI being integrated into your care? How do you feel about this or that application of AI? I think those are important. But what I would really love to see is us asking the question of where should we even start? Where should we focus this in general? I read in, one early AI textbook, AI is great at sort of generating the answers. It's great at sort of formulating the calculations and giving you the answers, but the folks who should be actually coming up with the questions are the humans. And in this case, the most critical human in the loop, if you will, the patient. So in some ways, I'm going to just punt that question a bit to say that I would love us to find out because we really need that patient perspective on not just, is this AI acceptable to you, but rather what are the questions that we should be answering to begin with.
Yes, you actually brought up a really important point. And this is something that I have learned throughout my career in public health and in creating programs that it really should have a human centered design focus. And who is the end user, the end outcome, ensuring that their voices are included. So the patient's voice is so critically important. And I think if we merged like you said, the AI, the algorithms that the providers are using, and all of the chat GPT perplexity that patients are now using, AI, different modalities to try and navigate their healthcare. I think it's critically important that we merge both of those together so that we come up with a better output and a better way to help providers as well as to help patients, because equity is critically important, and we know that including the voices of those we're trying to help is front and center. I can tell you here in California, that is one of our North Stars, is that whatever we create, that it should have equity in mind. Now, that being said, what does equitable AI look like in obstetrics? And what's a red flag that is it's performing worse for moms of color, for patients of color, black, brown patients.
That's a great question. And I'll admit that, as my work has sort of delved deeper into AI solutions, what has really fascinated me and what is really, I guess fascinated is a better way than saying kept me up at night, are sort of those concerns, specifically around bias in AI algorithms, which I think, in a good way has reached sort of a public zeitgeist as well. But I would say, generally speaking, when we consider any algorithm, whether it's an AI deployment or whether it's a simple algorithm, anytime that there is a disparity in performance across subgroups, we need to question that. So whether those subgroups are race and ethnicity, such as for black and brown patients, or that race, along insurance status or English proficiency, whenever we see those disparities in performance, we can't just sort of shrug and say, well, it looks pretty similar and it's a good model overall, so let's just go with it. Those are the times that you need to dive in and ask the question as to whether or not the model is really working as intended. And then even beyond that, a piece that really interests and excites me is actually really around bias mitigation using AI. So we have a lot of algorithms built off of a lot of data, and a lot of that data has, quite frankly, encoded our own human bias in it, and not necessarily the good kind. So I think of something like the VBAC calculator is sort of the one that overtly comes to mind. And while we can do some steps around, like removing race and ethnicity, which is lovely and all, what would be even better to actually do is, rather than just sort of say like, well, I don't see color, which I sort of consider removing the variables as akin to, but to actually use techniques to actually mitigate the bias inherent to the model. So actually code in and mandate, for example, these different metrics like predictive parity, to mandate equalized odds, that sort of thing, in the build of the model itself. So I think that AI, while it has this well-earned sort of bad rap around the potential for propagating bias in models, I do also, as a little bit of an optimist, reflect that it also represents the potential for mitigating it from the outset as well, provided that we continue to take this really active lens in building the models and in testing them.
Yes, I think you hit it right on target. Really addressing and eliminating the bias, asking the questions so that the bias can be eliminated. And I know oftentimes it's more patients of color that have a higher distrust for AI and for the algorithms, but that's where I think the more times that we ask the questions, redirect the direction, hopefully we can start to build and push the bias out or minimize it as much as possible. So, moving on to disparities and to another area where I think we have an opportunity to leverage AI and technology, that's the postpartum period. One of the things that I'm highlighting as part of my initiative to reduce maternal mortality is the fact that over 62% of the maternal deaths happen after the day after delivery, up until 12 months. And that's a time when moms are at home, out of the healthcare system, but they may be connected to some technology device, whether it's a ring, a phone, a blood pressure cuff. Where do you see the opportunities to leverage all of this remote monitoring with perhaps some AI algorithms or AI programs so that we can alert not only the patient but the health team that this patient who may be delivered 6, 8 weeks ago needs medical care because of cardiac conditions or perhaps anemia? Any thoughts, Dr. Wong?
Yeah, absolutely. And no, I really, as an MFM specialist, really appreciate this highlighted focus on the postpartum period, because I think that we honestly, it's exactly there's just such a gap in care and such a gap in transitions of care, in this space in particular. I think that the quote that I harken back to is that, the pregnancy is sort of like unwrapping the candy, and the wrapper. And so once you sort of unwrap the candy, you just discard the wrapper. And that's sometimes what it feels like for our postpartum patients. So to speak to sort of the potential for intervention, I will say this is an incredibly well-primed group, whether pregnant or postpartum. I mean, the reality is that this is one of the most internet connected, technology capable groups. Like, you can do a trial in heart failure all you want, not to knock the heart failure folks out there. But that is a wide range of people with wide range of internet access. If you look at the numbers in pregnancy, um, you know, in excess of 9 out of 10 people are gathering pregnancy and postpartum information online, and doing so on a daily basis. So this is an incredibly technology engaged group. I joke with people, but it's actually not a joke. It's just straight true that literally my wife and I Googled how to bathe our baby whenever we got home and watched a quick YouTube video on it. So even the trained among us can be incredibly untrained in certain areas. So I think it's got huge potential. I would say that AI has this incredible ability to integrate, and where I see it really bring value is in its ability to sort of summarize and do that initial triage, which would be, quite frankly, untenable for any individual clinician. As much as I would love to be able to sit down and really, look at all of the nuances of my patient's Oura ring, or be able to follow up in detail on their ongoing care. It's just untenable in the nature of how many deliveries happen versus how many clinicians we have. So I think that it would really take a systematic implementation of ongoing remote patient monitoring in the postpartum period. And I think it could be anything from as basic as ongoing symptoms monitoring to slightly technology enabled with remote blood pressure cuffs, particularly for our highest risk groups, all the way to really ongoing vitals monitoring. And admittedly, that really is where AI shines, in the ability to sort of summarize that information and trigger, most importantly, protocols and rapid response pathways to be able to then actually do something with that information, rather than what happens now, which is, you have your Oura ring or you have your, remote monitoring scale, and it just sort of sits, the information sits with you. So I think all of those represent tremendous potential and an incredibly technology engaged population who really needs our care, who needs us to, remember the wrapper, if you will, because they are understandably so focused on the whole human that they're responsible for, that they kind of also, will let themselves get discarded away, which I don't think we can do.
Great points. All right, the final question before I get to the questions I ask everyone. If we partnered statewide with health systems and payers, what is one AI or informatics project we could stand up in 12 months that would save lives now, and not in 5 years, but now?
I would say early risk assessment, even before the first prenatal visit. So some way to be able to identify those pregnant persons, which quite frankly is very doable. Target or Amazon will sure start sending you ads because it's that evident to them that you are pregnant. So a statewide program that enables early risk assessment and triage to appropriate prenatal care or appropriate other medical care as needed, whether that's cardiovascular care, care with endocrinology, that sort of thing. But it's that early period that I think that we have the most capability to impact not only the lives of the pregnant people, but also eventually of their babies.
I love it. You are giving a sneak peek to our preconception medical assessment that was just recently validated to assess and identify patients who are going to be at risk, who are going to be a high risk patient on admission to
Mm.
prenatal care. So more to come on that. So if folks are getting a sneak
Perfect
peek
plan
on
then.
that. Yes, yes. But thank you, Dr. Wong. The last two questions are questions I ask of everyone. The first one is, what does health and well-being mean to you personally?
I think, gosh, I think for me, it's really as simple as the ability to sort of be able to show up fully for, you know, fully for myself, for my family, for my patients, my colleagues, to be able to do that every day and to feel like I get to contribute and leave this place a little bit better than I found it.
I love it. And finally, what's one innovative idea to improve health in California?
Focus on pregnant people. And hopefully I leaned away from the mic when I said that since I got a little excited. But I think that, pregnancy just represents just such this closely monitored, closely health activated, just incredibly engaged time from both clinicians and from the patients themselves. I always tell people it's like, they hear my spiel, like pregnancy is the number one reason for hospitalization more than the next three combined. It is the one of the most common reasons for outpatient visits, right? So you see your doc, you get diagnosed with high blood pressure, you see them again 6 months later. Pregnancy, you might see them 20 times over the course over your pregnancy. So I think if we look to pregnancy as sort of a lens for the way that we can develop and scale and test and prioritize these innovations, I think that we will see real gains across the board.
Fantastic. And I oftentimes say pregnancy is a window to your future health because we
Mm.
know when there's high blood pressure, diabetes, depression in pregnancy, it's just a quick sneak peek to the fact that you are at higher risk for all of those conditions later on in life. So, Dr. Wong, this has been an amazing time. I am so inspired and energized by the work that you're doing. And I look forward to more of your publications, the work that you're doing to really help improve and merge technology, AI, and the clinical care. Thank you so much for the work that you're doing and look forward to speaking to you soon and hearing more of your updates. Thank you.
Thank you as well. Thank you.